First, I want to thank Andrea Barini and the sponsors for this Congress. At first, I thought I had a really good time because Saturday morning, you know, it's easy. And then I realized Dr. Barini schedules a disco the night before, so maybe half the people are still sleeping. Maybe that's an advantage for me also, I don't know. So first I want to say I have no disclosures. I don't have any stocks or companies. I just work for the university. And today I'm going to try to teach you or try to impress upon you the role of oocyte cryopreservation for cancer and also some of the special considerations when treating women who have cancer or have had cancer treatment. So as we heard from Dr. Barry yesterday, the indications for oocyte cryopreservation are rapidly expanding. So initially we were talking just about oocyte cryopreservation for cancer, but if you look, there's a whole really laundry list of reasons that is growing. For instance, even women who have severe endometriosis and require multiple surgeries. And one that is very important to me, which I know in Europe you often call it social egg freezing. I definitely don't call it social egg freezing. For me, that would be like saying that a woman coming for in vitro at 40 or 42 is having social IVF. And I think it's quite derogatory. So I think I just want to impress upon you that I think for women to have an adjective that's social, elective, or anything is quite upsetting to them in the United States, and maybe this will translate here as well. But today what we'll focus on is using oocyte cryopreservation in a woman who's newly diagnosed with a cancer who requires a treatment that will either remove the ovary or remove the ovarian function or perhaps only make the ovarian function lower, so decreasing the ovarian reserve. Well, so who are the patients? And I apologize that I only have the American data. This is American Cancer Society registry, where in America, about 700,000 women are diagnosed with cancer each year, and about 10% are in the reproductive age. And if you look, these are the cancers by site, and thankfully the incidence, which is in blue, and the mortality, which is in red, the incidence bars are much taller than the mortality bars for many of the malignancies. Well, breast is the front runner. We have almost 200,000 cases of breast cancer in the United States a year, and 13% of these are in the reproductive age. The GYN malignancies are 75,000 cases a year, so this is the second biggest group of women who will come for fertility preservation. And if you look for uterus, it's 8% of uterine, 12% of ovary, and 40% of cervical cancers are in the reproductive age. I think we now all are aware that cervical cancer is a sexually transmitted disease. And the last big group are the hematologic malignancies, leukemia and lymphoma. 65% of Hodgkin, 23% of leukemia, and 16% of non-Hodgkin's lymphoma are diagnosed in the reproductive age. And these tend to be the very young patients that you'll see for fertility preservation. I don't know how. But with the increased survival that has occurred with the oncologists, increased surveillance, better treatments, there's a big cost, and that is that any chemotherapy that you receive or radiation therapy to the ovary is going to cause compromise if the agent is toxic to the ovary. So if you give chemotherapy, it's going to go to every cell in the body that has a blood supply, and the oocytes will be destroyed, and you'll have accelerated atresia of the ovary. And we know that the biggest agent, the biggest culprit, is the alkylating agent. And I don't know if it's cyclophosphamide here, that's the same? Cyclophosphamide, Cytoxan, yeah? You call it something else, I don't know. So the alkylating agents. So for instance, for breast cancer, the alkylating agent is the most common treatment that we use, the cyclophosphamide. And if you look at the natural curve of menopause, I'm right in here, so I definitely have just gone through it. But then you compare that to if you get chemotherapy or you get chemotherapy plus the hormone therapy, the probability of menopause in the first year of treatment from breast cancer is quite profound. And if you look at the slope is the highest in the age of 35. So if you have a woman who's about 37 years old, she has about a 50% chance of having menopause, not just decreased ovarian reserve, but menopause from breast cancer treatment. And even if you have someone who's 33 years old, it's 20% chance of having menopause. And this is a problem. So people say, oh, well, it's just 20%, it's just 1 in 5. But for me, if this were my daughter, I would look at it more, the glass is half empty, not the glass is half full, because 20% is too high for me to risk menopause for someone who hasn't had the children. And again, it's the alkylating agent, and this data has been borne out by multiple authors since this first report in 1999. The other big gonadotoxic therapy, as you probably know, is the stem cell or bone marrow transplantation. And it's really the preparation for this treatment, the high-dose alkylating agent and the total body radiation, that leads to almost universal ovarian failure for these young people. So these are the hematologic malignancies often, who will require a very extensive treatment. And it's almost unquestionable whether they will have menopause from their treatment. So in 2006, ASCO, the American Society of Clinical Oncologists, had a recommendation paper that came out talking about the fact that fertility preservation is an important part of the planning of cancer treatment for patients. So the important thing about this paper is that even though it's quite outdated now if you read it, it actually reached out to so many oncologists. So there's 28,000 members in ASCO. It's the largest society we have in medicine. And so many of the doctors who wouldn't ordinarily read gynecologic information said, oh, fertility preservation. What is it? And it really started the dialogue between the oncologists and the reproductive endocrinology GYN world. And so it's very different now. Like Eleonora said, oh, well, she's an expert in the last 10 years. Really, the first time I learned about oocyte cryopreservation, Eleonora, was when you were giving the plenary session at ASRM. And if you remember, I basically attacked you afterward and said, I must be your new best friend. And so now I really thank you for allowing me to enter the world of fertility preservation. But in the background of that is this paper was coming out and really reaching out to a lot of the oncologists. So I thank this paper, even though it's quite outdated and not completely correct at this point, that it reached out to the other groups. So why is it such a big problem for women being diagnosed with cancer in the ages of 30 and 40? Well, I think another very important point that we need to pay attention to is that women are waiting to have their children. And I think you know it in Europe more than I know it in the United States. But if you look at the US Census data, for instance, the only groups who are having a rise in birth rate are women 35 to 39 and 40 to 44, which is very different if you look 20 years ago at the statistics. And the birth rate in the United States now is as low as the Great Depression. So it's very, very different. I mean, women just aren't having children so often, and they're not having them early. If you look worldwide at the age of first birth, it's actually a bigger problem on this side of the Atlantic Ocean than on our side. So if you look way over to the right, Spain, Italy, Germany, UK, you'll see now you're getting almost to the age of 31 for the age of first birth. That just, if you think about it from any other species, it just doesn't make sense what's happening. But the truth is that it's not going to change. So more women are being diagnosed with cancer who have not yet had their children. Well, when I thinking back over my career and my college and thinking about, well, when I had my children, the day I finished fellowship with Dr. Zev Rosenwax, I had a baby, June 26, 1992. The next year I had another baby. Before that, I didn't think I had time to have a baby. Really, you're going to have it in high school or college or when you're starting your job. There's really no time for men or women. There's no perfect time to start having your family. And I think this is the dilemma that we're all in now. So during that time when women are waiting, we're really losing the number of eggs. So 20 weeks in utero, you have the most eggs ever. You have 6 to 7 million eggs in the ovary. And by birth, you're already down to 1 to 2 million eggs. By puberty, when you're just allowed to first start procreating, you're down to 300,000 eggs. And on the ages that women are trying to have children, from 30 to 40, you go from 240,000 oocytes to 60,000 oocytes. So it's really unfair that this is when we're trying to have the children, and also in this time is when the oocyte quality is also decreasing. So we're really only fertile for this very short period. In the summer, I had to do a debate against Dr. David Albertini, who I trust very much, but I had to drive my car 6 hours to Penn State to debate with him. And so I was sitting in a hotel, in the restaurant by myself. I was kind of sad and lonely by myself after driving by myself. And I said, okay, what's the perfect woman? Okay, so I had my computer, and I said, if only the ovary was in the head and you took the brain out, then you'd have a perfect woman. I think everyone would say, right? Then you don't have to go to college. You just, when your ovary says you're ovulating, then you have sex, you have the baby. So it's really, the problem is that we have a brain. I'm sorry. And it's not going away. I'm just going to say, I think all the men would agree. If we didn't have the brain, we'd be perfect. But we do. So it's, oh, just ovary, yeah. Dr. Barini says, just have the ovary, no brain. Yeah? Yeah. So in some ways, I wish I only had the ovary in the head, because then I wouldn't have so much stress all the time. So I think we have a design flaw. And now that I'm in Italy and I feel like I'm talking to God walking in the street, I'm going to talk to him, because I think we have a design flaw that we're most fertile when we're too young, and we're only fertile for 1/4 of our expected lifespan, which is just a big design problem. You know, it's just not working so well. So, but again, back to the cancer, which is really why you invited me here, Dr. Barini, is it's the problem why women are diagnosed with cancer and they haven't had their children, and that's really a big problem. So when you see the cancer patients, you have unique challenges different than the women who are coming who have a partner, new partner at 38. Okay, I just want to have a baby now. For sure, I just want to have a baby now, or I think I want. For cancer, they've just been told, maybe you're not going to live. So maybe they're worried about dying. They have a lot of anxiety about the treatments they're going to receive, chemotherapy, losing the hair. This is a big one for breast cancer. And now they're being told, oh, and by the way, maybe you're going to be sterile. Maybe they barely hear that message because they're so worried about everything else they're hearing. And importantly, maybe they haven't really thought about whether they're going to have the baby or not. So do I want a baby? Do I not want a baby? I think some women and men actually say, I'm not sure, and I'm not sure when. They also often are lacking the natural, the information about the natural decline in fertility. So, you know, they don't necessarily know that the oocytes are decreasing from 30 to 40. And so, you know, you have to educate them a lot if you're going to be the doctor. And the other thing is you have very limited time. So the doctor texts you, you know, you're in work, you get the text, oh, I'm sending the patient this afternoon. Can I have her in 2 weeks? Yeah, sure, it's no problem. Yeah, no problem. Just send her right now. You know, I have full office hour, no problem. So that's really how it goes. But if you want to do oncofertility, you just have to be available all the time. So what do we have? We have women who are diagnosed with cancer, and now they're surviving. They have no or low number of children, and they have a fertility desire, or maybe they don't even know if they want a baby yet, but they're sitting in front of you saying, maybe I'll have oocyte cryopreservation. So the option Dr. Barini asked me to talk about today is oocyte cryopreservation. Well, I'm not sure if everyone in the room is aware, but over the last 5 years, many people have been pushing the ASRM, the American Society of Reproductive Medicine, to remove the experimental label from oocyte cryopreservation, because it's the biggest issue for us. It's different than where you have national health care, is our insurance companies won't cover oocyte cryopreservation if it's got an experimental label. So when ICSI was new and it had experimental label, patients even with very severe male factor could not have coverage. And now with this removal of the label, it's going to make a big push to have the insurance companies cover for these young girls. Because what happens is, if I see someone who's, say, 15 years old with leukemia, and I call the insurance company and say, okay, she's having a treatment in 2 weeks where she will have no ovarian function. They say, I'm sorry, today she has ovarian function, so she's not infertile today. That's how our insurance company are dealing with it. And so now with this push, now with the experimental label off, now we can really push them. Well, in the paper of the ASRM, they cited only randomized controlled trials. You know how difficult it is to do randomized controlled trial. They cited the IVI group, you know, Anacobo, looking at the government sponsored randomization of fresh versus vitrified donors, where they saw no difference in pregnancy rate. They have Laura Rienzi's paper, and Filippo Ubaldi looking at where they used fresh oocytes and then frozen sibling comparison. And then Dr. Parmigiani's group, where they actually had a higher pregnancy rate with the vitrification than the fresh cycles. So you should be quite proud that you influenced the American Society of Reproductive Medicine. because it's quite conservative. Like here, they're quite conservative. I think in a positive way. They're quite conservative about their decisions. They also quoted the paper that I worked on with Dr. Barini and Dr. Porcu, where in 2008 we didn't know how many births there were in the world, and we put together a lot with Pablo also, with just putting together all of the births in the world to see how many there were, to push to say, no, it's not 100. Actually, at that time we found 936 births. And importantly, we saw no difference in the birth anomalies from fresh conception, natural conception in the US. Recently, Richard Scott's group looked at fresh versus frozen, using fresh versus frozen oocytes, and looking at aneuploidy rates in the embryos that are created. And again, importantly, no difference in the aneuploidy rates, whether the eggs were fresh or frozen when they created the eggs. And this recently came out in Fertility and Sterility, and they presented it last year at the ASRM. So again, back to cancer. I think, again, Eleanor, you have been such a force for me from the beginning. You've been such a force for me. Before I heard your talk, I really knew nothing about oocyte cryopreservation, and now all I do is oocyte cryopreservation. I sleep, I talk, I write. That's all I do is oocyte cryopreservation, and I really thank you. And so when her report of the first birth from cancer came out, that was also very exciting for me, because people said, okay, no births in the cancer patients, only non-cancer patients. Well, so what have we done at NYU? We have a very busy oocyte cryopreservation program. We do about 1,700 pickups a year at NYU, so it's a busy IVF program. At this point, we've done 1,100 oocyte cryopreservation cycles, and that's really since 2004, and it's really mostly in the last 3 years. So 80% are for deferred reproduction, and 20% are for medical, and most of the medical, almost all of them, are cancer. So of the 80 women the 80% who came for deferred reproduction, notice no social. We've done 63 thaw cycles, so people have come back and used the oocytes. And for the medical patients, we've had 5 oocyte and 4 embryo thaws, and I'll show you why that is. So this is the data for the non-cancer patients, the 63 cycles where it's not for cancer. If you look, some of them are oocyte donation. So the pregnancy rate, obviously, these are your best patients, so it's 67% ongoing or delivered. Only 2 of the patients are ongoing now. But if you stratify the data out in the patients who use their own oocytes, you see it's tracking like in vitro fertilization. So if you're under 35, about 50%. If you're 35 to 39, about 38%. And of course, if you're 40 to 42, it's going to be lower, but still, 15%. There's some miscarriages also, though, obviously, that are going to go up as you get older. So in general, I discourage women to freeze over 41. And I tell them I think it's ideal to freeze 38 or under. And I think that's going to be, it's like in vitro, honestly, when you think about it, too. I think in vitro, really, if you had your choice, I think you would only do in vitro 38 and under. So the ongoing live birth rate all in is 46%. And if you look at the autologous cycles, it's about 36%, and 1/3 are 40 to 42. So it's a little hard to turn away women who are 40 to 42. In fact, this baby was just delivered in August to a woman who froze at 41.5 and came back at 45, and she has no fertility now, and that baby wouldn't be here without oocyte cryopreservation. So for cancer, again, this is why you invited me, Dr. Barini. I'm sorry I keep straying. So after we documented success using oocyte cryopreservation, so first we offered 15 cycles where we didn't charge the patients. They used their own oocytes, so they're in that mix I showed you already. We made sure that it was working, so freezing and thawing and getting babies before we offered it to patients who had cancer. And we offer them both oocyte or zygote freezing. So we say you can use a donor if that's appropriate for you. If you have a partner, you can do it. It's not a problem. I know you have a problem for donor in Italy, but it's not a problem in the United States. In fact, until the ASRM released the experimental label, they were encouraging women to make donor sperm embryos for fertility preservation rather than freezing oocytes, which I was aghast, quite honestly. So we have, me personally, I have evaluated 166 women who came to ask about fertility preservation after they're diagnosed with cancer from April 2005 until October of 2012. And of 166 patients, 152 went on to have treatment with the mean age of 31. So most women who come are deciding to pursue the treatment. So maybe I'm very convincing, I don't know. But I think if they're coming for the appointment, and they have to pay, actually, only maybe 3 patients have had insurance coverage. So they want it so badly that they'll even pay to have this treatment. And I'm hoping very soon the insurance will cover it. But I'm just telling you that women who come for this want it. You know, it's not like, oh, maybe, maybe not. No, today, I'll do it today. So of the patients who have come, 53% did not have a partner at the time. And for me, partner is a committed relationship for 1 year. I know that's completely arbitrary, but if you just have marriage, well, that's hardly anyone anymore. So I said, okay, 6 months, maybe it's not enough, but 1 year, it's enough, okay? So 1 year, about half had a partner and half didn't have a partner. You never knew. I grew up very, very Catholic. I'm one of 7 siblings. I grew up so Catholic, church every day in London. It's hard to believe that I'm even a fertility doctor, quite honestly. But I've come a long way, I'll just say. So in the patients who are not partnered, so these are the women who don't have a committed, maybe they have a boyfriend, maybe not a little bit, but no committed relationship. So they're younger. Their mean age is 29. Almost all of them elected to do oocyte cryopreservation. 2 elected to do zygote freezing with donor sperm. And 1 elected to do half her eggs with her unfertilized and 1 half with donor sperm. This is the choice. So what the point is that these women are, they desire reproductive autonomy, meaning when they're finished with their cancer treatment, they want the ability to have a child with the person that they want to have the child with. For the partnered patients, they're a little bit older, but not so old. So the mean age is 33. They have a different selection, right? So about 28 chose to do oocyte cryo, 20 chose to do only zygote cryo, and 23 chose to do oocyte plus zygote cryo, meaning even if they had a partner, they would split half and half eggs, half embryos. And what that tells you is that 2/3 of the women, even with a partner, wanted to freeze some of their oocytes unfertilized. So again, even with a partner, they desire reproductive autonomy. And that's a very important point because some people don't want to say it in front of their partner. You know, I don't know if it's going to work out. Yeah, so you have to talk to them alone also. So this is the data on the 152 patients who had treatment. 10 actually went through 2 times, so that's 162 cycles. And if you look, like Eleonora said, breast is a big front runner in blue, GYN, and hematologic malignancies. And then there were 16 other patients, thyroid, thymic, sarcoma. Oh my God. That's no problem. Anyway, so mostly you're going to see the breast, the GYN, and the hematologic malignancies. Important to tell the oncologist is it takes, if you have a patient who they say, well, I must have them back right away, on average, it takes 17 days from the day you see them in the consult until you have the pickup. So, you know, I've looked at all the patients. This is the shortest mean time that it takes. They have about 10 days of stimulation, just like in vitro, and on average they get about 14 oocytes in the protocols we use, and I think that's a very good number of oocytes. And we compared that to our age-matched cycles who didn't have cancer, and it was no different. So it doesn't appear that cancer per se in women, like in men. So in men there's a compromise of the sperm. In women there's not a compromise. So if you look at the outcome by cancer type, if you look at breast, GYN, and hematologic, the breast cancer are the oldest patients. We know because they're diagnosed at an older age. The hematologic patients are the youngest. The partnered, both the GYN and the breast cancer were 50-50 partnered, and the hematologic patients are your unpartnered. These are your 15, 16, 17-year-old girls that you see with the hematologic. For the estradiol on the day of ovulation trigger, I pointed out for breast, they're in blue. I have the letrozole patients first and then the no letrozole patients because we actually now exclusively use the aromatase inhibitor for breast cancer, even if they're estrogen receptor negative. So we use the letrozole 5 milligrams with gonadotropin for all the patients. The breast cancer doctors like it better, and I don't think it's a problem, although I'd like to see more data on the births. And we use the GnRH agonist trigger with those patients as well, and no problem. But if you look for breast, with the letrozole, the estradiol is less than it's about 800 average, and we use full dose gonadotropin. So I'll use 450 IUs of gonadotropin with the letrozole. If you're going to stimulate a breast cancer patient, you want to get a good number of eggs. And so here's the oocytes again. With the aromatase inhibitor, even though the estrogen is low, you're going to have a nice number of oocytes. And again, the hematologic patients are the best, even though they have their full tumor, their cancer. At the time you treat them, they have a very good response to the medication. So someone said yesterday that lymphoma patients have decreased ovarian reserve. I have not seen that. And then I divided the GYN ovary versus the endometrium because the ovary patients don't do as well, and the endometrium patients are often PCO. I see I have to wrap it up by the time, so I won't say too much more. I'll skip this. So a few things, just so we use the quick start where we use an antagonist plus birth control pills, and I can send anyone the link to the paper. We wrote a paper describing all these. We've done it in 68 cases, meaning that the doctor sends them and says, oh, I must have the patient back right away. So follicular, luteal, no matter what, you start the antagonist with birth control pill, and we have good egg number and good mature. We've done 51 patients who are 25 years old and younger. And so if you look at their estradiol curve, you see many of these young patients are very good stimulators. They're a little bit hyperstimulated. We use the antagonist, the agonist trigger, and we have no OHSS problem. 2 patients that had Hodgkin's had low. One didn't respond to the agonist trigger at all. So we gave her the agonist. We went to do the pickup. No oocytes. So we gave her the HCG trigger that night, and we did the pickup again 34 hours, and she got 26 eggs from the other side. So I have no idea why it didn't work. Another Hodgkin's patient, we gave an agonist trigger, and she only had 3 oocytes, even though the estradiol was 3,000. So 2 times I've had, what happened? So I would say for the very, very skinny patients who have hematologic malignancy, I would be careful because maybe the HPO, the hypothalamic axis, isn't so active. And we did 1 stimulation of a 15-year-old who didn't have her period yet, so premenarchal, and we were able to get 17 oocytes. So if the woman, even if she hasn't had the period, if you look at the ovaries with ultrasound and you look at the hormone levels, I think it's okay to try stimulation. I have to skip all this, I think, because Dr. Barini will kill me. But I think really just for the fertility, if the patient has had chemotherapy, you need to talk to the high-risk obstetrics and the oncologist to make sure they don't go having a triplet or a twin pregnancy in somebody who's had a lot of chemotherapy, because maybe for the anthracyclines, there's cardiac, with the bleomycin pulmonary, and with the platinums, maybe some kidney function. But the point really is to have a multidisciplinary approach to these patients when you're dealing with them after the chemotherapy. And again, because of multiple birth, you might uncover some of their problems by having, say, a twin pregnancy where you have more fluid load, and then maybe they have a little bit of compromise of the heart or the lung. So you just have to make sure they see the perinatologist before. I think... I don't know. Okay, so this is the last slide I'll show you. So this is really what you want to know. So we've done, in the medical thaws, we've done 9 patients have come back and done 14 thaws. So in the top is the patients who only froze oocytes. These are patients who only froze embryos. And these are the patients who froze eggs and embryos. And if you see the patients who come back, they're young. The average is 33 years old. 3 of the 9 patients who came back needed a gestational carrier because, again, remember, you're dealing with GYN cancers often, and so they had a hysterectomy as part of their treatment. 2 of the patients have had a baby, and 1 of these is ongoing again already. And then for the egg freezing thaw, we have 1 woman who froze at 40 and a half, and now she had a baby in April at 43. So she took her tamoxifen for 3 years, and now she's delivered her baby. And I get to see this baby because she's a very special patient. So I believe she's the oldest patient, unless Eleonora has older, who froze her eggs and then used them for a cancer survivor. So I think that's all I'll say. Let's see. Nah, we'll skip this because he'll kill me. Okay, so the conclusion is that oocyte cryopreservation success has improved dramatically over the past decade, increasing the clinical applicability to include oocyte cryopreservation for cancer. Prior to fertility preservation treatments, patients require thoughtful counseling about the realistic statistics and options related to their own reproductive goals. In the setting of cancer, fertility preservation can often be achieved, although potential risks and disposition, for instance, what's going to happen to those oocytes if they die, and third-party reproduction need to be considered and discussed. And last, the recent removal of the experimental designation in the USA will help to assure that oocyte cryopreservation will remain a clinical option for women wanting to prolong reproductive potential. So I end by showing you, this is the street of my beach house 1 week before I came to see you. I wasn't sure I was coming to this meeting because there was 3 feet of water. This is the driveway right here to my house. 3 feet of water in the street, but I think now it's gone. I don't know. I'm making believe it's not happening, but today I'll find out when I go home. So thank you.